for the invitation. And I would like to thank the moderator, Professor Dr. Nagla. My talk today will be about ERCP emergency. Yesterday, I had a talk which is the essential in ERCP. So the two subjects are nearly close to each other, so forgive me because most of the slides will be repeated again today. So forgive me for that. Again, the ERCP started in 1968, and it was a diagnostic technique. And then after a few years, after sphincterotomy, it became diagnostic and therapeutic. With the advancement of the image technique, it became only therapeutic approach. ERCP in conjunction with cholangioscopy, AUS, can diagnose and treat most of the pancreatic biliary disease. Just reminding you that the medical care could be general care, emergency, and urgency. Emergency means medical problems that needs immediate intervention within a few hours. On the other hand, urgency means medical problems that need intervention as much rapid as you can. So sequentially, we can classify the ERCP emergency into emergent indications and emergent complications. The complication could occur either during the ERCP itself or post the ERCP. So regarding the emergent indications for ERCP, first one of them is the acute severe cholangitis, with or without pancreatitis, pancreatic biliary duct perforations and peritonitis, hemophilia, and sometimes, in some cases, acute cholecystitis in non-surgical candidate considered to be also an emergent ERCP. The guidelines accept that classification, that the ERCP indication could be emergent and could be urgent. The emergent, you have to deal with it within a few hours, from 6 up to 12, not more than 24 hours. On the other hand, the urgency can be scheduled within 24 hours up to 72 hours. Also, the guidelines recommend you have to avoid the complications of the post-ERCP pancreatitis by using non-steroidal anti-inflammatory, suppository, and sometimes proper hydration before the procedures, and sometimes after the procedures. Also, they recommend antibiotic in some cases if there is suspicious of infectious severe cholangitis. Because the acute severe cholangitis is the most emergent ERCP, the Tokyo guidelines recommend certain criteria for the proper diagnosis of the situations by clinical, laboratory, and image technique. You have to evaluate your patients regarding that complication. Also, they recommend the classification of the severe cholangitis into mild, severe, and moderate, and accepting also the time to interfere with that complications or with that emergency. In spite of that, we can use the old traditional evaluating system, the Charcot triad or the modified Reynolds triad, to evaluate the situations of the acute severe cholangitis as the most important emergent ERCP. All the guidelines of all of this society accept the same classification. This classification is mandatory to avoid either delaying the intervention by the ERCP, so predisposing the patients to the progression of the disease, or to decide to do premature ERCP, so predisposing the patient to the complication that may occur during or after the procedures. This complication could be in the form of pancreatitis, perforation, hemorrhage, cardiovascular events, and other miscellaneous complications. Some of the endoscopists believe that the failure is considered to be complication. From my point of view, I don't believe so, because I believe that failure with learning, you will reach the success. And that's why you should have multiple plans, preparing yourself to deal with that failure. Sometimes you may need another expert. You may do BTD, combined technique, AUS, and even surgery. All of these steps should be done under the concept of teamwork, acting together, because team means what? Together, everyone achieve more. We have to respect the share of everyone in the unit, and we have to remember that we is better and safe than me. Actually, I have been graduated at the late 70s, and I started my endoscopic career more than 40 years ago. And during that time, I shared in many workshops. One of the best of them was in Mansoura, and I have the honor and happiness because it was with my friend, Professor Hafner, at that time. During that long time, I built up my own principles before I decide to do an ERCP for a patient or an endoscopy for any patients. I have to look for these 5 principles, and it's built by me. First one, I have to know the indications to do that procedures regarding the clinical, lab, and image criteria. Number two, I have to think about the alternative. What's the alternative that may be more suitable for the patients rather than the endoscopy or rather than the ERCP? Number three, I have to look for the options to deal with the complication. I have to anticipate the complication and I have to prepare myself to deal with that complication. Number four, I have to explain everything to the patient about his problem. How can I help him? And even the complication that may occur. And he should write down a consent about that. Finally, I have to know when I have to stop, because it's not a personal challenge, it's the benefit for your patient. By that, we can avoid that nightmare of the complications of the endoscopy. The following statements summarize my little experience regarding endoscopy in general and ERCP specifically. Number one, you have to know when you have to stop and to think about other options to help your patient. Number two, you have to remember that failure is better than catastrophe as long as you are following the standard of care steps, as long as you are following the guidelines. Number four, you have to remember that you have to convince the patients that failure without complication is considered to be an acceptable outcome, and there is another alternative by which you can help your patient. The last one, not to do it and to respect the other subspecialty that may help you is better than failure and catastrophe. And I think this is the wisdom. At the end, you have to do all of that step in a gentle way. As Gandhi said, in a gentle way, you can shake the world. The medicine is the art of the MDT. And I believe that the MDT is not only multi-speciality, but it's also handling of multiple ideas within the same specialty. The most important member in this team, the patient himself, who should know everything about his disease, how can we help him, and even the complication that may occur. And we should give him the chance to take his decision. And thank you very much.